of a situation where you've tried to use MI, it worked to a degree, and then it just seemed to not get them far enough. So we have it happen similarly where people, they're talking in a very motivated way, but somehow they're not making a change. And we sometimes think that that's because there's like a skill deficit in some ways, right? Like they really want to do this, but they're not quite sure how to make it happen for themselves. And they keep getting stuck on, they try to do the things that they think will work, and they just don't quite work as well as they need them to, and so they keep falling into the trap. The second way that we see that happen a lot is with people have other mental health conditions that are really leading it, that the substance use is in some ways benefiting them in functioning in a particular way to aid them in managing their mental health symptoms, but at the same time is costing them this other way. So it's sort of like, I want to give this up, but I recognize that if I do give it up, I give up the thing that helps me not feel depressed. You know, the young man I saw this morning, that was kind of what he described, so depressed. This would mean giving up the thing that brings him the only joy he experiences in life. So it feels like an impossible ask. He recognizes all the costs, you know, being hospitalized, he can't think straight right now, he's gotten psychotic, like, all those things he recognizes are problematic, but the flip side is so costly, and until we can replace that with something sort of like, well, it's going to be hard. So we see that also in personality disorder, with borderline personality disorder, where people have a lot of emotion dysregulation. Well, suddenly the substances might have helped them feel more in control of their emotions. So if we take away this thing that helped them feel better, it's kind of an unfair trade. Like, until you teach me something that helps me get regulated in the moment, it's going to be hard to give this up. And then we have the trauma. We have a lot of people where trauma is a big part of it, and we recognize that, again, it's sort of like the panic symptoms, the impacts of trauma are alleviated by substance use. And you end up in these really kind of horrible situations where people have the sense that the only way to get through trauma is to talk it out. And while on some level that is actually been correct for lots of studies, like most of the treatments we have for trauma involve some kind of exposure, something about talking about the history. That's not true for all of them, however. So it's important to keep in mind there are some good trials now of things like using yoga, using EMDR, where you don't actually talk about the trauma, but you're having more a body experience that works through the difficulty without necessarily having to articulate it. Now, on the other hand, there can still be a re-experiencing in your body of this, and so long as you've been using substances to alleviate that discomfort, then engaging in a treatment that's going to make it worse temporarily feels like, again, it's a setup for people using more heavily. So at our hospital, and I'm just trying to think of, then you have people where they've got a goal in one area. And you might appreciate that the goal in that area really makes sense for them, right? Like they're socially isolated, so you work on it. And while you might appreciate, I think you've lost your family connections because they're so infuriated with you about your substance use, that it gets better by investing in this, but then you fall short because you haven't quite tied it together that it's linked to your substance use too. You fail to recognize it as a consequence of the substance use. And in that way, you might set a goal. And in MI, we've respected the person's autonomy and recognized this is the goal you're willing to work on, so we work on that goal with you. But there's a way in which you remain a little bit, delusional is a bit too strong, but you're kind of like, in denial of the connection with how the substance use created that problem. And so those are times too where I feel like we need to help build the connection together so that you can appreciate that, well, maybe I need to take that next step too. So when we thought about all of this, and we thought about what have we done at St. Mike's to solve this, is that we have kind of a collection of different therapies that we're building up over time to offer people. And then we thought, which ones could we give you a clue of and some of the skills that we use there so that you could easily take them out into other settings and start doing them. So Wiplav and I kind of talked about what we think are those key elements. So we thought, MI is crucial because if you don't have an engagement with a person, you don't have a connection, it doesn't matter what you say, they're not interested in listening. So you need that first. The next thing we feel is that we've been using something called CRA, Community Reinforcement Approach. So motivational interviewing was born in the same place that CRA happened, which is interesting because they're while they take two different approaches in terms of what you do in the room, they have very similar attitudes. Now, CRA, because it's a behavioral treatment, is a little more pushy than motivational interviewing. So what we think is we do MI, and if not being pushy has helped completely, we're done. But if not being pushy didn't help, now we get pushy. Now we get pushy in a very nice way, but we get a little bit more pushy. And that's how I see CRA. It's like a nice MI kind of consistent approach, but it's not entirely MI, because we are trying to get people to make those connections that before they weren't making. So the happiness scale is a way to get people thinking about recovery is about more than just substance use. But it also includes substance use. So when you do that with somebody who said, like, oh, I got the family, you just go like, what's your level of happiness in your drinking and sobriety? Or drug use? What's your happiness in your job or educational progress, in money management, in social life, in personal habits, in your marriage and family relationships, in legal issues, in emotional life, in communication, and in general happiness? Because if you find that general happiness is low and everything else is high in happiness, you want to say, what is affecting your general happiness that I did not catch so far, right? This is a useful way to like engage. If in MI we do that sort of agenda setting where you put the bubbles on, you have people fill in the things you want. This is a way to kind of go through it in a really stepped way to make sure you're covering everything that you could imagine. Does that make sense? Because you don't want them to avoid an area in their life that's a complete wreck, but they don't really want to talk about. This kind of helps it bring it, I'm not happy with it. So you can see from this sort of thing a way to start saying, oh, so you're not happy. Can you just tell me why that's, a 5 and not a 3, like the classic MI thing, right? Like why is it, what would help it? What would get it higher? And that's how we then focus our goals of counseling. So if you've recognized that you're not happy in an area, so in that area of drinking sobriety, what would you like to be the case? And in the area of job and educational progress, what would you like? So it's taking someone from this is a problem into how would I like it to be? So like MI, we want this positive, future-focused type of thing. Well, what would be ideal? And this is how we begin helping people develop the goal, and then working on a plan for changing that, and the time frame they'd like to get that changed in. It also becomes a way to start tying together how these other areas might be related to substance use, just like we would do in motivational interviewing, where we try to explore the connections between the family and your substance use. But here we have a few more areas, so it might be easier for someone to kind of recognize that there's this connection between these areas. So we need to teach problem solving to people. Many people with substance use problems, they lack a kind of problem solving, and they feel overwhelmed. They just use drugs and they feel better. They don't solve the problem, they just use drugs. And now they feel better. Now the problem isn't gone, the problem is still there. So actually teaching people a very specific skill on how to solve problems is part of CRA. The other thing that's true is that mostly in substance use, that the relationships around a person who has a substance use have gotten toxic, angry, confrontational, and disruptive, right? The relationship with their spouse is normally quite strained, and so we need couples therapy and communication skills, and that's part of what we teach as well. The other thing is that people often have lost employment, right? And in fact, they haven't got something productive and motivating to get them up and doing something in the day. And so we want to do job skill training and counseling and help them get connected to work. That's another key part, is getting people employment counseling as part of this kind of therapy. The other part is that we know that people's social life has gotten restricted down to just doing things around drugs generally. There might be the occasional thing, but normally you can talk to people and they realize, well, I used to play hockey and then we went out for beer afterwards. Now I don't go to hockey, but I join them for beer afterwards, right? And there's this way in which all of those social recreational activities that they had have gotten whittled down bit by bit to just substance use socialization. And so we do rec therapy to try to get people exploring back into those social activities that give them pleasure. Now, this is all based on a very simple principle. And the simple principle is it is far easier to replace a behavior than to stop one. We do need to work to have the person think in this substitution way. You've got people you're hanging out with, and they're all substance users. We need to figure out where else you can get your social needs met that doesn't involve drinking, that doesn't involve using drugs. Now, the next part of this is the reason why so we need it to be reinforcing, right? It's why it's a reinforcement approach. We need it to feel rewarding that you spend time with these people not using. Okay, what's more fun, do you think, for a person? Getting high on crystal meth and having sex, or not getting high on crystal meth and having sex? Which one's better? Getting high on crystal meth and having sex, right? That's why these people are doing it. It feels good. You have a competition here that healthy ways of getting needs met do not deliver the wham, fabulous impact that you get. Now, there are some people who have tantric sex, and they're probably enjoying their sex life as much as the people who are having sex on crystal meth. So to get good at tantric sex, what do you need to do? You need to practice, right? Now, this is true for all healthy behaviors. Is for them to deliver their advantage, you need to practice them over and over again. No one goes to the gym on the first time and leaves looking like Arnold Schwarzenegger. I wish. Suffering, I do not believe, is experienced any differently in any person in this room, no matter the origin. And no suffering trumps another. See, in humanity, I believe all suffering is suffering. It is only in this classification of my suffering is worse than your suffering that we end up in these problems. And that for each person to actually get through it, they have to find a way to transcend their suffering and actually find a way to be hopeful for themselves. And so whether that's a person who has had terrifically horrible things done to them, or it's someone who feels that like they are cheated out of that extra $1 million, if the person's going to learn to not suffer and not turn to drugs or alcohol, they have to find a way to soothe themselves. That doesn't take away from a larger picture issue, which is about what is just and fair in society. This is about if someone is with me and they're using substances to make themselves feel better, that mechanism is the same regardless of you do that because you don't like the fact that you're not making $1 million or because you were sexually molested and taken from your home and treated horrifically. You know, there's additional things that might need to be done for the person that's got trauma because their whole belief system has been shifted. But it's in the shift of the belief system and the reshaping of a belief system that's important. So I don't hold to your premise because I actually think that the mechanism is the same. The stakes might be higher, but the mechanism is the same. The stakes are higher, that's why we probably see higher rates of substance use problems in LGBT communities, in those who have sexual abuse histories, and those who have been physically abused. So it's not that it doesn't hold. Like, I don't think that, like, because we have a principled stance about how to help someone, I don't think it helps them to believe that they're disempowered and, well, you've had a shittier life and therefore what? You can't overcome it? Like, what would be the natural extension of thinking in that way? Like, I think if we're going to be optimistic for a person, we have to believe that, in fact, they can transcend this. Because they need to feel empowered to transcend it. I don't want to be a, you had this done to you and now we'll rescue you mentality. I want to be, it might have happened to you, and someone may have done this to you, and it might have been not at all your fault, but I still want you to feel empowered that you can choose how to be happy, how to accept the things that have happened. I don't think radical acceptance is something that's only, in fact, I think that radical acceptance is harder for people who've had severe trauma and more important. I may spend my time working with trauma victims with horrible sexual abuse histories. And it is really hard to get to a place of accepting their role in suffering. But it doesn't mean it isn't there. And it's not about blaming them for the trauma that's happened. It's about holding to account how you will have a perspective on life that will be freeing for you. But I actually think that we need a consistent and theoretically sound way to treat. And I actually think thinking about suffering, understanding the function of substance use, and figuring out how we empower people to take charge of their thinking to feel better is critical. So now, healthy behaviors deliver their advantage in the long term. This is why we feel so this is part 2, it's not all parts, but part 2 of it is, if we're going to have the substitute, it's not going to reinforce in the same way, and the person needs a realistic expectation before they go in. If they think sex is going to be the same, not on crystal as it is on crystal, we are lost at the beginning. So we need to make it perfectly clear that, like, playing soccer will eventually be fun, but will be mostly uncomfortable for the first few games, right? Now, people who play soccer a lot, they don't have the same discomfort any longer, right? Once you have acclimatized to a healthy behavior, the costs are minimized. So in CBT, we talk about thought records. In CRA, we do functional analyses, and you do a bunch of them. And it's like the core part of helping a person understand what's happening with their substance use. This is how it's different than motivational interviewing in that it's guided. Like, we are going through in a very methodical way to find out what were the triggers for your substance use, and what are the triggers for the healthy things you used to do that you're not doing anymore. So maybe you used to play on a volleyball league, and now you don't play on the volleyball league anymore. So then I find out, well, what were the triggers of the volleyball league? Like, who were you with when you went to play volleyball? And when did you normally play volleyball? And where did you go to play volleyball? And the internal triggers. What were you thinking about just before you went to play volleyball? What were you usually feeling physically before you went to volleyball? What were you usually feeling emotionally before you went to volleyball? You can ask those things about substance use, and you ask them about any healthy behavior. Because there's this thing where the triggers, our mind is associative. If every time we go to do this behavior, there's these precursors that lead up to it, like you go into the change room and you get changed and you joke around with your pals, and then you go out onto the floor. Well, then there's this pattern that cues you that it's volleyball playing time. And there's probably a whole series of cues that happen leading up to getting to the gym to play volleyball. So those triggers, if it's substance use, we want to avoid those triggers. Because if you're in face of those triggers, if you're walking by the bar you normally drink at as you leave work on your way home, or as you leave your therapy hour to go home, then you're more likely to drink because you're getting triggered. So avoidance of the external is helpful. Now, you cannot avoid internal triggers. Those you need better coping. So then we have to teach you some better coping skills for the internal ones. On the flip side, if there's triggers to the healthy behaviors, we don't want to avoid them. We want them in your face all the time. So if you are thinking about your running shoes before, you put the running shoes in a very prominent place in the house. You put a volleyball somewhere in the house. You make a cue that reminds you of this thing you enjoy, right? Now, it's no use to give people recreational activities that they can't stand. So you need to find things they actually have interest in already. Maybe they did them as a kid and they stopped for some reason. And you're like, well, other adults still do this thing. Why can't you? Right? Well, I'm not good at it. Well, maybe not yet, but you enjoyed it then. Why not just do a pickup league? You like dodgeball? Fine. There's dodgeball leagues in Toronto. Right? You start figuring these things out. So now the next column, there's the behavior, and then there's a difference. There's short-term negatives from healthy things and short-term positives from unhealthy things. And then there's long-term positive for the healthy things and long-term negative from unhealthy things. And this is actually a good way to define things that are healthy versus things that are not healthy. Is it a savings account, or is this a credit card? Do you accrue debt, or do you invest in yourself? which way is it coming out? If you're paying the cost up front, but you're accruing some benefit, like when you do yoga or meditation or going to the gym or playing at a sport or doing a craft, doing something artistic, if you get better and better at it over time and you get more and more benefit and enjoyment over time, well then it's healthy. But if you are getting the benefit right now, like a credit card, and then you are paying an 18% debt and interest on it for the next 5 years, well, that's not a particularly healthy thing. And that's the kind of substitution we want. We want to figure out, if we can figure out the function. Now, the other part of why this is useful is that if you start looking at this column of the short-term positive consequences of substance use, you'll see that they're exactly the same questions that are in the triggers, internal and external, for the use. The idea here is to figure out, so who are you normally with when you decide to go drinking? John. And what do you like about drinking with John? Well, he's really funny. Okay. And where do you go? Well, I go to the bar. Well, why do you like drinking there? Well, everyone knows me. Oh. So now you're starting to build, and what are you feeling emotionally before? Well, I'm feeling a bit lonely normally before I go drinking. And how are you feeling after? Well, I feel kind of, happy. It's noticing the differences that lets us figure out the function. I've just given you an example where the function is a social function. The drinking is to not be lonely. The drinking is to feel connected with people. All substance use has a function. Most people have 4 to 5 functions for their substance use. And if you can figure out what those functions are, you can replace them. When people relapse, it's typically because they thought it had 1 function or 2 functions, and they replaced those, and they forgot about the ones that happen much less frequently, and they didn't plan for them. So often what happens, people come in, they talk about their drinking because it makes them social, because it makes them not feel anxious, because it makes them feel less depressed, and they don't think about how it also helps them celebrate. So they go along great until Christmas and New Year's happen, and then they relapse. Because they have no substitution for celebration. They got one celebration strategy, and that is get blotto. So figuring out all the functions is critical. Now what you normally do is you ask the most critical ones. You say, what's the most common pattern? And you fill in the functional analysis for the most common pattern. And you say, what's your next most common pattern? Now you can figure out patterns by saying, like, do you have a weekend pattern and a weekday pattern? Do you have a special occasion pattern that's different than a usual pattern? Do you have a certain type of person you do one thing with, you drink in one particular way, and a different way with someone else? Do you have a, cocaine all night long, all weekend long pattern because I don't need to work, versus I'm seeing my family tomorrow cocaine pattern that looks different? You want to figure out each of them and discover what the function is in all of them. Also, what the triggers are, because you might need different avoidance strategy and different coping mechanisms depending on what the function is. So now I got 2 principles out in the open right now, right? We want substitution, which is why we talk about the fun things too. We do functional analysis on this. Just like motivational interviewing, we never end on the good things about using. We want to say, is there a downside? And we get that out. Or we talk about what would be the cost of making the change, but what would be the benefit of stopping using, right? We always want to end on the thing that's a little bit optimistic or a little bit could lead to change. Similarly, in this, we do not end on the short-term positives of drug use. So we always fill in the long-term negative consequences so we get that balance, right? Things that trip people up. People find a function in their substance use, and they find recreational activity. Their function of their substance use is to be calm and peaceful, and they think they're going to substitute it by joining a boxing class. It's like, that makes no sense. Yoga, that would make sense. Now, the person who's using stimulants to be really excited, who says, I know I'll meditate. You want to be excited and horny, and you're going to replace that with meditating in a seated position. That's a recipe for failure, right? The second time you come in, I talk about, well, what about the healthy stuff that used to do that? And then I want to make that feel very optimistic, right? That's why now, that one, in that session, I can get through 2. Because you can do them a little bit faster because the first one, it takes you about a whole session to get them understanding it. Now you do 2. After that, then I try to figure out, what do I need more of? Is there other critical patterns that we have to uncover? So maybe the next session I get 2 more substance use ones, or maybe even 3. And then the next time I want to fill in other healthy things that start targeting the actual functions I've identified. So here's another thing that happens in a functional analysis that's really useful. You get to the functional analysis, you've gone through all the triggers, and then you go through the long-term costs of drinking or substance use. And then you can have this moment go like, oh, do you see that? Look what you put here under emotion. You said feeling depressed gets you thinking about substance use. And you say being depressed is the long-term consequence of your substance use. Wow, that's a trap. Because if you try to say that to the person, they will ignore you. But they have just put it all out there, and they're like, oh, you're right. This is a way to build insight for people. You will find things in this column that are right over here in the trigger columns. And that's useful. Because now the person sees that you really are circling the drain, but you're actually walking a spiral staircase. It's not passive. You're creating this thing that is also your trigger. And so then you can say, but wait a minute, we could do the opposite, because we could be making that the positive long-term consequences are the triggers that make you feel good and want you to do those healthy things. But this means you have to move from a credit card mentality, I need it right now, to one of saving and getting it later. Which means, are you an impatient person? That's normally the question I ask at some point. I finally get to that. Do you tend to be a little bit impatient? Like you kind of want things right now? And if I've played this right, the person will go, well, yeah, kind of. So yeah, really? Well, so what other ways are you like that? And I just reinforce it. I said, you could change that, don't you think? Because most people want to believe they can change that about themselves. And that is kind of at the core of this, right? It's like, and it's fed by a society that is a credit card society. We want things now, we'll pay later. Thank you very much. I remember my mother with these books, and like $20 or $30 went into this account every month for my clothes so that I got a spending spree in September for new clothes, which I hated doing anyway, but my mom had planned it that way, right? She also did the same thing for the car, right? Money went outside, and then they bought the car with cash because they had done it. My mama just got sat down and worked out it because it's going to cost a lot less if I don't have a debt for it. She would put the money aside for when the car broke down. It was a very useful thing for me to have seen because it is a way of thinking that's very different than most of my patients see the world. They see, oh my goodness, this is horrible, I gotta fix it now, as opposed to, I need to have built up the supplies that no matter what comes at me, I'm ready for it. So, and one way to think of it is the A-B link, antecedents to behavior, is referred to as classical conditioning. That is you ring the bell and you give the food to the dog. Ring the bell, give the food. And eventually you ring the bell and the salivation happens without. The behaviors of salivation. I pair something, I do this association, and that's the A to B, our antecedents to behavior. And while that helps us with avoidance strategy, it doesn't teach us the operant conditioning part, which is what were the consequences that reinforce the behavior. And so the part of the power behind CRA is that lots of drug and alcohol treatment programs have focused on triggers to substance use and haven't focused on consequences of substance use in a way to make sure that people have substituted consequences. Does that make sense? So it's not surprising that that's the sort of stuff because a lot of us have been trained to ask about those triggers to make sense and to help people think like, oh, the people, places, and things you need to avoid, right? But this is kind of seeing a little bit different, saying, well, there's also been this benefit that might have been hidden or maybe not so hidden, and we want you to get the benefit, but not in this way because it's costing you way too much. So then, and that's just a slightly different, and probably operant conditioning is it takes a little more work to dig out. The person with that substitution improves outcomes because it's hard just to stop something. That's the white knuckling people describe in 12-step traditions, to say people white knuckled it. They manage to not drink, but they don't feel like they've got a substitute because they're just not doing it. So having a substitute gives you helps match the function, the need that's underneath the function. Then we have that you have the second principle is that for healthy things, the substitutes need to have their own reinforcers, right? They need to be functional for you in a certain way. And the third principle is that if you're paying a cost, so if you have a functional analysis and you realize to do this healthy things, to go to the gym means your muscles are uncomfortable and you're sweaty, or to sit in the meditation cushion is uncomfortable and makes you, whatever the costs are, those costs are more easily overcome if you do it in a social situation. So we find it easier to do healthy things if we do it with people we care about. And so the third principle is build a network for people of people they do these recreational activities with, as opposed to doing them alone. Because as you build community around people, it becomes reinforcing itself to do those things.